Vitiligo is one of the most well-known and important skin conditions worldwide. Welcome to a new episode of Octopus Pharmacist Derma, where we explore this condition in detail. What exactly is vitiligo and how does it develop? Are there different types of it? How does the doctor confirm the diagnosis? What are the 6 most important and widely used treatment steps available today? When does the doctor decide it's time to start treatment? And finally, when does the doctor choose instead to help the skin lose its remaining color to achieve a single unified tone? Stay with me. Peace be upon you all. I'm Hassan Lotfi, and I welcome you to the Octopus Pharmacist channel. Today, we begin a new episode of Octopus Pharmacist Derma, where we focus on one of the most known skin diseases. At the start, here is today's title. If you want the exact title, just play the video for a moment and you'll see it appear on the screen. But if you want to really understand everything about vitiligo, stay with me from the first minute until the very last one. Now, as we always do together, let's go step by step and take in the key information. 1. Definition. What is the definition of vitiligo? It is a condition where the melanocytes, the cells that give your skin its natural color, stop working. When these cells stop functioning, they no longer produce melanin, the pigment responsible for skin color. This doesn't mean a slight fading of the skin. Instead, it causes clear white patches because pigment is no longer being made. 2. Causes. So, what are the main reasons melanocytes may stop working? There are 3 well-known and important causes. First cause, heredity. Vitiligo can run in families. The chance of passing it on is around 30%, meaning if a parent has vitiligo and has 10 children, about 3 or so may also develop it. Second cause, autoimmune diseases. In these cases, the immune system, which normally protects the body, mistakenly attacks it. Examples include Hashimoto's thyroiditis, affecting the thyroid gland, type 1 diabetes, Addison's disease, affecting the adrenal glands, psoriasis, rheumatoid arthritis, certain types of anemia. In such conditions, immune cells may also attack melanocytes in the skin, stop them from working, and cause vitiligo patches to appear. Third cause, localized factors. Here, the condition may stay in one place and not spread across the body. 2 theories explain this. The neural theory. Sometimes, nerves under the skin release chemicals called neurotransmitters in very high amounts. These chemicals damage melanocytes in that specific spot, leading to 1 or 2 stable patches that do not spread further. The Koebner phenomenon. This happens after an injury, cut, or repeated friction to the skin. The trauma causes immune cells to attack only that area, and vitiligo appears there, staying fixed without spreading. 3. Common locations. Where does vitiligo usually appear first? It often begins in the neck, the jawline, around the nose and mouth, the fingertips and toes, the armpits and groin, the lower abdomen, the thighs, chest, and even the genital area. From these spots, it may spread to other parts of the body over time. 4. Contagious or not? A very important question. Is vitiligo contagious? The answer is absolutely no. Vitiligo is not caused by bacteria, viruses, or fungi. So let us not treat patients with fear or avoid shaking their hands or act as if they are dangerous. They already carry a heavy psychological burden, and we should not make it harder for them. 5. Vitiligo and cancer risk. Another key point. Does vitiligo turn into skin cancer? In reality, this is very rare. It happens only if a person exposes vitiligo patches directly to the sun for long periods without protection. Normally, melanin in the skin helps protect us from sunlight, but in vitiligo patches, melanin is missing. This is why using sun protection is one of the most important steps for people with vitiligo, to lower the risk of sun damage and protect the skin. And with this introduction, you now know what vitiligo is, why it happens, the most important causes, the places it begins, the fact that it is not contagious, and it's very small, but real linked to sun exposure and cancer risk. Stay with me in the coming sections of this episode, where we will go deeper into its diagnosis, types, and treatment options available worldwide. The second topic we have today is, what are the steps to diagnose vitiligo? 1. Clinical examination. First, the doctor begins by looking carefully at the shape and distribution of the patches on the body and the areas where they have spread. He then examines the skin using a special ultraviolet light called a Wood's lamp. Here, the doctor focuses on the edges of the patches. In many cases, the edges appear darker than the normal skin and sometimes a little swollen or reddish. At other times, the edge shows what is called a trichrome pattern. This means you see 3 colors in one area: a pure white patch, then a light brown area, and finally the normal skin color. These signs are very characteristic, and they help the dermatologist recognize vitiligo quickly and with confidence. 2. Skin biopsy. Another step the doctor may take is a skin biopsy. This means taking a very small sample of the skin and examining it under a microscope in the laboratory. What will we find? In the affected skin, there are no melanocytes, the cells responsible for skin color. At the same time, on the edges of the patches, we often see many immune cells attacking. This confirms that vitiligo is indeed an autoimmune condition. 3. Blood tests. The third and most important step is a blood test. Now you may ask, why should the patient pay extra if the diagnosis is already clear? The answer is simple. Vitiligo is usually linked to other autoimmune diseases. That's why a good dermatologist will always check for other problems, such as blood sugar, to check for diabetes, thyroid function, to check for Hashimoto's or other thyroid issues, joint markers, to look for autoimmune arthritis or related conditions. In this way, the doctor makes sure whether vitiligo is standing alone or whether it's part of a wider autoimmune picture. 4. Scoring systems. Finally, after completing the examination, the doctor gives the patient a score. There are established systems, such as VTF or VASI, that help the doctor measure the percentage of the body affected, how widely vitiligo is distributed, and the activity of the immune system behind it. These scores are very useful to decide on the best treatment plan and to track improvement over time. With these steps, examination, biopsy, blood tests, and scoring, the diagnosis of vitiligo becomes clear, accurate, and complete. Now comes the big question. Is there hope that we can start treatment for vitiligo? Can we reduce the overactive immune system that causes this problem? Or, on the other hand, when the immune system is very strong and vitiligo already covers more than 20% to 50% of the body's surface area, at that point, we usually do not treat by restoring pigment. Instead, the approach changes. The goal becomes helping the immune system finish its job and remove the rest of the pigment from the skin, so that the entire body is unified into one single, even color. The third topic today, treatment options. This is what really matters to most patients. When your patient asks you about treatment, you should know that we currently have 6 main categories of vitiligo therapy. 1. Topical treatments. The first option is topical medication. Here, doctors may use topical corticosteroids or a group of drugs called calcineurin inhibitors. The 2 most commonly used are pimecrolimus and tacrolimus. The choice of drug, strength, and duration all depend on the patient's situation. Long-term use of topical corticosteroids is generally avoided because of side effects like thinning of the skin. For this reason, calcineurin inhibitors, especially for sensitive areas like the face and neck, are often preferred. If corticosteroids are used, they're usually limited to 1 to 3 months only. 2. Phototherapy, light therapy. The second method is light-based treatment. This includes excimer laser, narrowband UVB, and in the past, puvotherapy, Sorolin plus UVA. Puva is rarely used now because of risks like premature skin aging and even skin cancer. Light therapy is very effective, especially when combined with topical drugs like tacrolimus or pimecrolimus. However, the main drawbacks are it requires 2 sessions per week for several months. If there's good improvement, the treatment may continue for up to 2 years. Side effects are usually mild, temporary redness or itching after sessions, which fade quickly. 3. Systemic oral treatments. The third option is systemic therapy, where drugs are taken orally. Since vitiligo is caused by an overactive immune system, doctors sometimes use medications that reduce immunity, such as cyclosporin, methotrexate, or low-dose oral corticosteroids in special regimens called mini pulses. For example, dexamethasone 2.5 to 4 milligrams may be given 2 days per week, over a course of 3 to 6 months. These treatments can be combined with other methods to enhance results. For biologic therapy monoclonal antibodies, the fourth and more modern option is the use of biologics, especially monoclonal antibodies. These are lab-designed antibodies that target specific immune signals. In vitiligo, the focus is on blocking certain immune pathways, known as JK-STAT signaling. 2 important drugs are ruxolitinib topical JK inhibitor, tofacitinib or similar oral JK inhibitors. Ruxolitinib cream has been especially promising. Applied twice daily, continued for about 1 year. Visible results appear in 4 to 6 months. Safe, effective, with very few side effects. This is one of the newest breakthroughs in vitiligo therapy. 5. Afamelanotide implant therapy. The fifth option is afamelanotide, a special implant placed under the skin. This drug mimics the natural hormone alpha-MSH, alpha-melanocyte-stimulating hormone. Its role is to stimulate stem cells in the skin, encouraging them to turn into new melanocytes, which then start producing melanin again. Afamelanotide is especially powerful when combined with light therapy. The implant stays under the skin for about 2 months. A common side effect is that the skin may darken more deeply than the surrounding natural tone, but this is temporary. Once the implant is removed, the skin gradually returns to its normal color balance. 6. Surgical treatment, skin grafting. The sixth and final option is surgical therapy, used in cases of stable vitiligo. What does stable vitiligo mean? It means the patches have remained unchanged in size and shape for a long time. No new spots are appearing. In such cases, a doctor can remove a thin layer of normal pigmented skin from another part of the body and transplant it onto the depigmented area. This method is similar to techniques used in burn treatment and can restore color very effectively when done correctly. Summary. So, to recap, topical drugs for local control, light therapy for stimulating repigmentation, systemic medications for immune suppression, biologics as modern targeted options, afamelanotide implants to boost melanocyte activity, surgery for stable cases. And remember, if the disease spreads to more than 50% of the body, sometimes the strategy changes. Instead of restoring pigment, the doctor may help the skin lose its remaining color for a uniform appearance. These 6 categories represent the most important and effective treatment steps available in the world today for vitiligo. The fourth topic with us today. The doctor has decided that none of the usual treatments are working with the patient. The immune system is very strong, and the area of skin affected by vitiligo has spread to more than 20%, sometimes even 50% of the body. This means one thing: the immune system is much stronger than the drugs we usually use. So what we do then? In this case, we reverse the approach. Instead of trying to stop the immune system from destroying melanocytes, we actually help it finish the job by removing the remaining color in the skin. Here, the doctor uses a special substance derived from hydroquinone. You may ask, isn't hydroquinone usually used only for temporary lightening, like in patch tests? And you're right, regular hydroquinone only suppresses melanocytes temporarily to reduce pigmentation. But in this case, we use a stronger compound called a monoether of hydroquinone. When applied to the skin, this substance doesn't just reduce pigmentation temporarily. It completely destroys the melanocyte cells themselves. In other words, it works in the same way as the immune system that is attacking melanocytes. But here, we do it deliberately, in a controlled way. This treatment is powerful, and just like hydroquinone, it has strict precautions. It can cause irritation, redness, and sensitivity. That is why, as we always say, using sunscreen is absolutely essential, not only during treatment, but even for patients without vitiligo. Sunscreen is a key protection step. With depigmentation therapy, you may see around 20% fading in the entire body and up to 40% fading in tougher areas like the knees or elbows. Now we come to the fifth and final section of today's episode. These are the most important instructions and pieces of advice we must always give to patients with vitiligo. First, patients with vitiligo often suffers from severe stress. Some may even enter depression, and unfortunately, in extreme cases, this can lead to suicidal thoughts. So, we must remind ourselves and our patients, vitiligo is not a fatal disease. It can be managed step by step, and patients must always feel supported. Second, I will repeat this point for the third time. Sunscreen use is non-negotiable. Protecting skin that has lost pigment from sun exposure is not only a cosmetic issue, it's a safety issue because depigmented skin, if left unprotected, has a higher risk of turning into skin cancer. Third, not every white spot on the skin is vitiligo. There are many other causes of light patches. Conditions like pityriasis alba, post-inflammatory hypopigmentation, or other harmless skin variations. The distribution and appearance differ. So the golden rule is always go back to a dermatologist. Only the dermatologist can confirm the diagnosis and decide the correct treatment. Fourth, this is especially important for women. If a woman has a close family member, a first-degree relative, with vitiligo, her own chance of developing vitiligo can be as high as 30%. For such women, using strong chemicals like aggressive hair dyes, keratin treatments, protein straighteners, harsh wax methods, or tattoos can sometimes trigger vitiligo to start. Once triggered, it can spread and may not stop. Fifth, patients with vitiligo should not rush to cosmetic solutions like tattooing or micropigmentation in the affected area. Why? Because vitiligo patches have no melanocytes. There are no pigment-producing cells left. So if you apply pigment around the area, you only darken the surrounding skin, while the vitiligo itself stays white. This makes the patches stand out even more. Sixth and last, do not run after advertisements, fake products, or so-called miracle cures from unknown sources. Vitiligo is a condition that needs long-term, step-by-step care under the supervision of a dermatologist. Sometimes the treatment succeeds, sometimes it doesn't, but every step must be taken with patience, with proper medical guidance, and never with false promises. And please remember, there is no special food, no diet that can restore pigment. Vitiligo is an autoimmune condition. Nutrition alone will not bring back skin color. And with that, today's video from Octopus Pharmacist Derma comes to an end. I hope I have provided you with new and useful information. Finally, don't forget, if you enjoyed this video, support the channel by liking, subscribing, and sharing. And also, if you'd like to help us continue, you can support through Patreon, PayPal, or YouTube. Have a great day. Hussein Lotfi.